So I think we are having a very interesting session about complications in cath lab. And so what I will try to do is, talk not only at a technical level, but more at a philosophical level uh, on how to deal with complications in cath lab. So basically, one thing, important thing to understand is, oops. चलो, ठीक है, उधर नहीं आ रहा. So, friends, I think this is, I think, the final talk. So please be patient because we'll get it over soon. So, as I said, important thing in cath lab is you have to think like a fighter pilot. So I think that is one of the important things. Interventional cardiologist is like a fighter pilot. 90% of the procedure is in mind. Only 10% is in the physical realm. So I think this very important thing you should remember, that you should always plan the patient. The whole procedure should be in your head from start to end, along with plan B and plan C. So you should know, in this patient, this is what I'm going to do, and mentally do the whole procedure. But if this happens, then this is what I'm going to do. And if this happens, then this is what I'm going to do. So basically, it is 90% of the complications can be presented if you already run the procedure in your mind. So I think that is important to know. Understanding how to prevent is more important than actually treating them. So that is important thing. So what are the issues in PCI? What are the things that you need to look at? Number one, patient condition. Number two, lesion condition. Number three, the procedure that you are planning, that you have to consider whether it's a straightforward procedure, whether it requires the use of a new technique, whether it requires the use of a new hardware, what is the skill of the person doing it, that means your own skill, and what is the condition of cath lab. So I think you need to look at all these things at the time before you start doing the procedure. Now, as I said, preventing complications is like fighting war. So you have to win with minimum casualty. And as I said, you are like fighter pilot. The only difference between you and fighter pilot is that once you are in the jet fighting, then your life is at risk. Here, the patient's life is at risk. So that is the only difference. Otherwise, similarities are there between you. So if you think of doing PCI or preventing complications like fighting a war you are raging, trying to prevent any complication from happening. So there is this very important Chinese philosopher, Sun Tzu, and what he said was that if you have to win a war, you have to look at 5 things. And this is, as a matter of fact, taught by the Marines, US Marines. This whole strategy is taught to even US Marines, this very old philosophy by Sun Tzu. And what it says is you look at 5 things. Number 1, choose your weather. Number 2, choose your terrain. Number 3, choose your general. Number 4, choose your strategy. But most importantly, have the people's benefit at heart. So here the people is the patient. So patient's good should be at your heart, trying to do good to the patient at all times. So I think that is one important message. Now coming to terrain, in context with cardiologists, what is the terrain? The terrain is cath lab. This is your terrain. So you have to see whether the cath lab is properly equipped. So before starting the case, make sure that all things are available. Now, also the operator should be conversant with the cath lab. Now, it's not a very good idea going to some other lab and doing a live case, because that can lead to many complications. Therefore, it has been seen that once people do live cases, there are more risk of complications happening actually. So you should be very conversant with your own cath lab. The cath lab staff should be well trained, including yourself. The crash cart should be available nearby. Always, before starting the procedure, check whether defibrillator is working, whether crash cart is available or not. And then also make sure, if possible, the CT-based support is also present. Now, coming to choosing your weather. So what is weather for interventional cardiologist? Here, weather is the timing of the complex procedure. So once you are planning a complex procedure, always remember the difficult case should not be the first case. It should not be the last case. It should not be at a time when people are hungry. It should not be at a time when people are full. It should not be at change timings when you think nurses are going out, technicians are going out, and at that middle of that time, don't plan these complex cases. And also make sure that surgeon is available. So that is also timing, because surgeons finish the case and sometimes go home. So you plan cases at those times. So I think that is important to understand. Now, choosing the general. Of course, general here is you. So you cannot unchoose yourself, unless you think it's a very complex procedure, and then when you might require a senior help or something. But the important things, those characteristics that you should possess is, number one, very important, you should follow a procedure. You should be stickler of method. Don't try to do things here and there. Just follow a certain method and always follow it. Second, of course, you should be skilled in preventing complications. So I think that goes without saying. But the other thing is that you should have a cool temperament, and you should be in control, as Dr. Anil also said, that don't lose your cerebrum while you are doing these cases. Always, whatever is happening, it is happening, but you are the one in charge. You are the fighter pilot. You cannot lose control of your jet. So that's why you have to remain in control of the situation at all situations, irrespective of what is happening to the patient. Other thing is, as I already mentioned in the beginning, once you plan a difficult case, you already run the case through your mind from start to end. This is what I'm going to do, this guiding catheter I'm using, this wire I'm using, this preparation I will use rota, not use rota, I will use an imaging catheter, not use a catheter, whatever. You run the whole case, and then you think that if something happens, this is my plan B. If plan B is not working, this is my plan C. So as I said in the last cases, as Dr. Anil also said, this is a person who's likely to have perforation. If it happens, then this is what I'm going to do. So make sure those things are available. You have a covered stent available with you or not, in a case where you think perforation can happen, or in a case where embolization can happen. Do you have the snares available with you in case you have to retrieve it? Or you have those proper dilatation balloon catheters, non-compliant high pressure balloon catheters or not, if you want to crush the stent to the size. So those things, I think you should make sure. And if that happens, go to plan B, go to plan C. Then another important thing, characteristic of an athlete. Remember, athlete always thinks while performing the athletic thing. So always on the run, athlete is thinking. Likewise, a cath lab operator should always keep thinking while things are going on. So think on the run, take quick decisions, and then go for them. So I think that is important. And finally, as I said, have the welfare of patient in mind always. Always think, I have to do best for the patient. Don't think of anything else at that point of time while you are doing the procedure. Of course, key to managing complications are threefold. The anticipation, as I said, you see the patient wheeling in the cath lab, you feel, no, I think something is wrong. Patient is not looking good. So you start anticipating. Then if you have a method in place, you will avoid the complication. If you have already thought about it, you have thought of the problems that are going to happen, 90% complications can be prevented because they are in mind. And then finally, if it happens, of course, you have to do whatever is required. Now, basically, complications can happen at 3 times, all of us know. But as I said, 90% complications are in the pre-procedure time. So if you properly plan your procedure, 90% complications can be avoided, but some will happen during the procedure. And finally, there are certain complications that can happen even after the procedure. Like Dr. Anil showed you, those guide wire perforations which happen to the distal vessel. So those perforations can happen 6 hours after the procedure, 3 hours after procedure, 30 minutes after procedure. So they can be late complications or results of embolizations. If it goes to cerebrum, they can develop CVA later on. So those complications can happen even after the procedure. You have to remember that work is not done just completing the procedure and running away. They have to be shifted and they have to be monitored properly for at least near future. So as I said, pre-procedure is the key, and the key is properly choose your case, properly choose your strategy, run the whole strategy in mind. Then based on your strategy, properly choose the hardware, properly choose your technique, and also you choose your operators or assistants. Because you know that this is a complicated case. Dr. Anil was referring again and again to his assistants. So mostly he was choosing his assistants in those complex cases because he knew that things could go wrong and therefore have the right people in place. Then, as I already discussed this, that 90% is in mind. So 90% complications can be prevented if you run through your case, especially the complex case that you are going to do. Proper case selection. Again, I think we saw through the things. Somebody was mentioning about the sole remaining artery. Whenever you are in this situation, the sole surviving artery, I think, as it was already discussed, start thinking of Impella device to be put in or IABP to be put in to give extra support to the patient. Always anticipate. Because even why the single remaining artery is important or sole surviving artery is important? Because while doing the case, even if a small amount of embolism happens, then whole heart is dependent on that artery. If something happens to the circulation, then practically whole heart is knocked off. And then there is a huge chance of death on table. That's why the sole surviving artery is very important. Likewise, anybody with poor ejection fraction, because already the contractility is impaired. Small impact on contractility will lead to a catastrophe. So you have to look at the ejection fraction. Then calcific, thrombotic, tortuous lesions, all those complex lesions are already there. Left main bifurcation with triple vessel disease, cardiogenic shock patients, or patients with comorbidities like renal failure, uncontrolled diabetes mellitus are all risk factors which you need to know before taking up the case for the procedure. And this is just a sky list of the risk factors: clinical, procedural, and anatomic, which give you an idea where complications can happen. So here is a case. This is like CTO, and sure enough, the perforation happened in this particular case. So if they had anticipated it, they could have prevented it, or they would be ready to treat it if necessary. Here is another case, a calcific thrombotic left main lesion with LAD occlusion, a very high risk case, very recipe for disaster if not done by an experienced person and with a proper cool. Here another case, large artery, but look, huge thrombus, a recipe for no flow, a recipe for, sudden collapse of the patient, because such big RCA, if it gets distally occluded, there will be a huge problem. Another important thing, post-CABG cases. Now, people might think that post-CABG patients will not have, even if they have perforation, will not have tamponade. But problem is that they are more complicated and there is more risk. And here perforation happened and a Jome stent, which is a covered stent, was put. So this is another. Then sole surviving artery, no right and tight left main disease. So if something happens in embolism happens in left main, patient is just crashed. Patient will not make it. So this is some of the things which you should keep in mind while selecting cases. Maybe not for beginners. You need seniors' help. You need more devices. You need more hemodynamic support in these kind of cases. So don't rush to do those cases. Then, of course, proper selection of hardware. Obviously, you could even do CT before going for the actual procedure. And through CT, you can see the course of the vessel, where calcium is existing, where you might encounter problems. Then proper selection of guide catheter, that you already know, proper selection of guide wire, proper selection of balloon catheter, properly kept covered stents, micro catheters. Dr. Anil already showed you where you could use a micro catheter, and imaging catheters, and then distal or proximal protection devices where there is a high risk of embolization, and then thrombectomy devices to remove the thrombus as well. So, and here is an example case: improper guide, see non-coaxial guide. And so you can see osteocoronary or osteoaortic perforation, type 2 osteoaortic perforation, very risky case. Fortunately, as this is one situation when you have a proximal or ostial and aortic perforation, where you stent this dissection immediately or this perforation immediately rather than trying to tackle the distal part. This is one situation where you actually handle it very quickly. Then, of course, proper selection of technique. And in technique also, not only the procedure, also look at how much contrast will be required. So you calculate the dose of contrast, 4 into creatinine clearance, maximum 6 into creatinine clearance. If you are using more contrast than this, you will do well, but late complication will happen and they will develop renal failure. So that patient is not benefited. Keep patient's benefit in mind. Doing procedure is not that important. Patient's benefit is the most important thing. That is why we are doing the procedure. Also, how long are you going to do fluoro? There are cases where fluoro has been given so much that burns have happened into the patients. So also remember these things are important. Then sometimes in CTOs you take bilateral access to know the retrograde part of the artery. Also, already discussed proper vessel selection, proper vessel preparation, whether by balloon dilatation, by rota or cutting balloon, whatever it is. Then thrombus extraction where necessary, imaging where required. So these are, I think, the common things that you need to do. But during the procedure, I think important thing is, of course, the technique should be good, but you should always stick to technique. Never try to jump here and there, miss some steps, never. For example, if you do bifurcation, always remember to do final kissing balloon dilatation. Always remember to do a proximal pot. So these are the steps, and you always remember to do. If you are doing left main, always remember to do imaging. So don't skip this particular step in left main case. So that's what I mean by sticking to technique for that particular case. And of course, adapt when necessary. But very important thing, what happens when patient collapse? Everybody starts shouting. And there is a total confusion. Nobody knows what to do. Always keep the communication channel ready. Only the person who's doing is the head. He's the leader. He should communicate with everybody whom should be doing. Not everybody shouting, you do this, you do that. So I think that is a very important thing. Even, think when patient collapses, what one is going to do, who is going to do what. So I think that is also important. Finally, I think, as I said, technique is important. And here there was a case of under-deployed stent. Technique was not followed. No post-dilatation was done. And there was a thrombus, acute thrombus. And ultimately, again, the whole process was done. So acute thrombosis happened because the proper post-dilatation of the stent was not done. Here another case where there is a damage to the stent stud because it was over-dilated. And then one had to put another stent inside this stent to cover up this thrombus, huge thrombus that had been formed. So again, the proper technique was not followed. Properly stent size was not calculated. Then plan B, as I said, once things start going wrong, always think about them, have the plan B ready. Here, the stent embolized, and you can see that it is being retrieved. So this is the plan B or plan C. Retrieval is always plan C. First, you try other things. If not possible, then you go for retrieval. So, but if necessary, you have to do. But crushed stent is the plan B. So this is a case where the stent was crushed, and I think I already showed you this case so previously. Then I think very important, don't be egoistic. Be ready to call for help. Whether it is a junior, whether it is senior, sometimes juniors are more skilled than you. Many times seniors are more skilled than you. No, have no ego. Because patient's benefit is in your mind. You are not, your ego is not your goal. The goal is patient's benefit. Whether if junior can do the thing, if somebody else can do the thing, if you can call more people, then I think that is the best idea. So this is important. Other things I already told you. Clear communication I already discussed with you, so I will not spend any time there. Finally, as I said, procedure is not over till the patient gets discharged. So even after the procedure, you have to look at guide wire perforation, retroperitoneal bleeds can happen, contrast reactions can happen, and cardiovascular, cerebrovascular accidents can happen. So you have a very good staff, very trained fellow in the CCU also, who can pick up these complications once they start happening and immediately inform you so that you can take corrective steps. So here is that case which you could not see, where trying to cross the aorta, there was in the severe AS, the calcium got embolized, and then finally it was actually crushed. And here is a case of guide wire perforation, and you can see that there are some strategies. I think Dr. Anil already told you, so I will not spend any time there. So I will conclude because Dr. Srinivas is looking at me again and again. So I will now quickly conclude that complications happen even in best of hands. If somebody tells you that I have never had a complication in life, means he has not done enough procedures. If you do enough procedures, then you will definitely have complications. So they happen in best of hands. I think that is important to realize, but still most of them are preventable. 90% are preventable. Proper choice of patient, lesion, strategy, technique, hardware can prevent most complications. But if they happen, keep plan B, plan C ready, and be watchful of the whole procedure. As he said, look from Kashmir to Kanyakumari. So keep that, while you do the fine print, you have the big picture in mind, and the biggest picture is patient's benefit. So keep that in mind. So thank you so much for your kind attention.